Welcome back to Clinical Communication. Today I'm speaking with Joe Gibson, who is an upper limb rehabilitation specialist and international lecturer for shoulder rehabilitation. Today, we're discussing around difficult conversations with people with shoulder pain, as well as helpful communication skills and tips in general. If you find this useful, then please do go and subscribe, and please do go and share it with other people. Please do let me know what topics to cover or guests to get. I hope you enjoy it, and thank you for watching or listening.
And humour's massive in Liverpool, absolutely massive. They just have the most incredible natural wit. So I think not taking yourself too seriously, and just smiling and being a nice person. I mean, they genuinely are out to communicate. They are naturally just an incredibly friendly and open kind of group of people, really. It's been a real kind of lovely place to live, and that's why I've stayed.
Good. Thank you for doing this, Joe.
Thank you for asking.
Giving up your evening to do this. And I will say to everyone now that we're not talking today about any of the clinical reasoning about diagnosis and specific exercises and tests and scans and all that stuff. Joe has her own course of that and various online resources and various podcasts which you go and listen to. Today, we're just focusing on the tricky conversation bit of it. We'll talk about some general communication stuff and then some shoulder tough conversations as well. Joe, we were chatting in the past, way before we arranged this, and I asked your permission in advance to ask you this, but you informed me that your dad's a psychiatrist. Are you still practicing or retired?
Unfortunately, he's no longer with us, Ben. He died very early after having leukemia, which was ironic because that was one of his specialist areas. But yeah, he died when he was 67.
I'm very sorry to hear that.
It was a long time ago. Don't worry.
What influence did he have on you?
Huge, absolutely huge. So he was kind of, I mean, again, he became a psychiatrist when it was not cool to be a psychiatrist. So he'd always kind of dealt with difficulty, I think. But he was definitely somebody who lived to work and had a massive passion for what he did. Now, as a kid, that wasn't necessarily something that I particularly liked because it meant he wasn't there very much. And I think what's probably sad is I probably only realised just how much of a contribution he'd made once he was ill and once he wasn't there anymore. And perhaps if I'd been a bit more open, I would have actually benefited from him a lot earlier in my life. But he basically just transformed how medical students were taught in terms of communication skills. But he also had this, again, very much what I love, what you kind of purport is the importance of healthcare professionals and the impact they have on patients. So his big interest was psychiatric oncology. He had a research unit at the Christie's Hospital in Manchester and essentially did a lot of work about breaking bad news, about helping parents with kids with leukemia and also women dealing with mastectomy. So those are his big areas. But then he was commissioned with by the government with his team to set up a communication course that you may have heard of, the Connect course, which was very much for breaking bad news, but then became open to other healthcare professionals because they realised the knock-on in other areas of healthcare. So and he did a lot of research about the best way to teach communication skills. So he was very much, training the actors and filming the interactions and all that kind of stuff. But I guess even further, so that's kind of his professional and the influence. And I kind of always aspired to make a difference and be as passionate about what I did. But I guess the other thing that always resonated as a kid, whether it was me or my friends, is my dad had this ability to ask a question.
Okay.
And reduce you to tears in a second. And you're kind of like, what happened? But, something really innocuous. And yet he'd somehow know what was going on, or he'd pick up your nonverbals, or he'd said something. And he was just watching that in action was incredibly powerful.
These particularly deep questions? Or was there something about these questions that made people?
Not necessarily. It could have been something really simple about, well, how do you feel about that? And it was just, like I'd ask him a question and then he'd bounce it back with, yeah, but how do you feel? And it'd just be like, you what? And I remember talking to him about so when I was first a physiotherapist, I had a colleague who very sadly lost her arm after being hit by a bus. And I remember saying to Dad, I said, it's just impossible. How do you say to somebody, I'm so sorry, this is awful, because can't say, oh, it's going to get better. And he said, well, why do you need to say anything? Why can't you just sit and listen and say, yeah, it's horrible, and let her talk and maybe let listen instead of everybody trying to make it better, because you can't make it better. It's horrible.
Mm.
And so I think that just got me really interested in the power of listening and just actually less is more. And so, well, I'm sure we'll talk about it, but ultimately I did a master's, and one of the modules was communication. And that was after dad had died, sadly. And they were just putting all these papers up on the screen. And I remember having to take a moment and go out at one point. But it was very cathartic and but also incredibly powerful to go through his course myself, because the Connect course was part of that. And yeah, I suppose I kind of want to keep that passing and keep that message out there, because I know that's the thing that mattered most to him.
And is that Connect course still going now?
Well, as with many things, there's always people wanting to modernize and do
Mm.
things differently. So I
Yeah.
don't think it still exists in exactly the same way. But I know the people that were involved and kind of did his training have taken it on and will continue to improve it in line with the evidence. So there's very similar things still available for sure.
So he was, if I've got this right, like the start of your communication journey.
Absolutely. Yeah, 100%.
Is he where the your phrase of communication being a superpower, is that where it comes from, or where does that come from?
No, it's when you asked me that question, I kind of communication, where did that come from? And when I look back, I actually had to go through all my lectures to see the first time that I used it, because I'm sure I haven't made it up. I know that it's elsewhere on the web, but me consciously using it was, I think, doing the 3 R's lecture in Manchester, when Jack Chew and the gang were really trying to kind of put some of the things on the agenda. And I was asked to talk about the biopsychosocial model. And it's a bit like, everybody's a bit like, oh, we're so over listening about this, and it's how do I make it interesting? And I thought, you know what? I just need a tagline that's going to get people really engaged. And so it was like, you're all this emphasis on what you do, but it's the how you do what you do. And so that's why my last slide was, guys, communication is your superpower. And then I was asked to do a similar talk. And so the title was Discover Your Secret Superpower. And so I think there's just so much in the evidence now that kind of almost undermines what we do as clinicians. For me, it was about a really positive message, but also trying to get people a bit interested, because I think we have these discussions, can you get better at communication, or do you naturally have it? And I think unless you know what the skill set is, how do you know you're good at it or not? You've got to have something as a framework. And I'm a bit of a glass half full. So I think that communication is your superpower was part of that. Look, there's a lot of really good stuff we can do. And the irony is that's where most of the evidence is, in our evidence of effect. So seeing it as a superpower is quite cool.
Yeah, yeah, I think so. As because that was big. So when, what year was that? We're talking like 2015, 2016, something
Yeah,
like that.
yeah.
Is just the message growing? Do you think we're talking almost 10 years ago now?
I think it is, but it's really interesting when I speak to other colleagues that are really interested in this. I think if you incorporate it as part, I mean, it's part of my clinical course about treating shoulders for sure. It's where I start and where I finish.
Mm.
But I think when you try to get people to sign up for communication courses, unless they're in a job where it's signposted the importance of that, I'm not sure people still prioritize it as part of their learning. And I think what was lovely at the hospital, and I know is happening in a few places around the country, is when people see the impact, then they buy into it and it becomes part of the culture. But I think we've still got a lot of work to do
Yeah.
at both undergraduate level and postgraduate to kind of maybe just instill that as a bit more of an essential rather than maybe a bit of icing on the cake.
Yeah, almost have to make it more, yeah, as you say, appealing or
Yeah.
attractive, so to speak. Something that hooks you in, so to speak. Yeah, we'll see. We'll see how time goes, I guess. What since you've been developing obviously your own skills over the time, and you incorporate it into the your own course, what aspect have you found the hardest to learn or do
Do.
communication skills wise?
This is probably not so. Well, at the beginning, the hardest thing was being silent and quieter and learning to listen. I've loved listening to some of your podcasts, and Nick Livadis, who was doing the injection. Oh, the two of you just resonated when I did my communication course, because I remember there was a guy called Tom Donovan, and watching him demonstrate, and he was just so peaceful and quiet. And thinking, oh my lord, that is the antithesis of this noisy, over exuberant Tigger that comes in the room wanting to look at the whatever the next thing is. So I think and I think the other thing that was really hard early in the journey was realizing that I was unconsciously incompetent, in that I didn't think I was a bad communicator, but I was really bad at prematurely reassuring patients in my desperate need to help them. And I guess in those days, the fix rather than the facilitate, normalizing it'll be all right, it's same for everybody else, rather than understanding the importance of acknowledging that individual experience. And I think the other thing I found really hard, because one of the big reasons I did my master's was because I had the responsibility for all these young adults with complex, why we called it complex, I have no idea. That wasn't helpful either. But people who didn't get better in a way that we would expect. And we did all sorts of research and put them in fMRI scanners, and big surprise, found there was a lot in that psychosocial domain. But I found it so difficult to ask some of the questions because I was worried about what I'd uncover, or Pandora's box, and what would I do. And of course, as you'll know, then going on the communication course gave me the realization I just need to ask the question or signpost the relevance. And what's so powerful is I don't need to do anything about it. So I think the hardest thing I found was to get brave to ask the question,
Ah,
but then by doing it, it was so empowering, because rather than treat people for 6 months thinking, oh my Lord, I'm never going to get there, or knowing there would be a barrier at some point, we had those conversations so much earlier in the process. And yeah, so I needed to stop being a big sister, which I am, trying to sort everything out, and then facilitate patients by asking the right questions. And importantly, highlighting sometimes that I wasn't the right person. And I think that summarizing and reflecting what patients tell you, and giving that context is hugely powerful for them to sometimes say, well, actually, no, maybe I need some help with this.
Is there anything you've found that you say asking certain questions that can feel hard to ask in a way? So anything apart from doing it and on repeat and getting the experience, anything else you found that made it easier to do?
Um, so the one thing I also struggled with, it was, the thing you meant to say, is there something else that you think is important for me to know, or something else you worried about or like to discuss? And I kind of also, oh, is it anything else? Because it something sounded so direct. But actually, as it would suggest, saying, is it something else, patients were far more likely to tell them. But I guess if I think of a scenario, there's two key scenarios really. One where they might have something really horrible going on in their life, like abuse, bullying, whatever. And of course, I'm going to say, are you being bullied, abused, or whatever? But I usually give the context, look, this can be a symptom of our body trying to protect us. And it's a kind of get out of the situation. Now, I don't know what's going on, but do you think, how does that feel? Do you think there's something that maybe that's why you're kind of responding to like this to certain situations? And they might say, do I have to tell you? No, you don't. But does that resonate? And the very fact they've said that, that's all I need to know, because then we can start on the journey of who's the right person. And then I guess the other scenario I see sometimes, and again, this is no one's fault, it's just we all set out to do the best for people, but people who perhaps do a sport but don't want to do it anymore, but they don't want to have that conversation with the people around them. And so I'll ask the question, and that was actually the example I gave when I did my communication course. And this actor, I said to him, and is swimming something you still want to do? And he and he was just an amazing actor. He just kind of, there was this real pause, and he looked at the floor, and all his body language said, no, I don't. And then he looked to the person that was meant to be his mum, who went, yeah, of course he does. And I started crying, and the actor was crying, and I was just like, oh, this is so awful. And Tom, the facilitator, said, Jo, why are you crying? I said, what have I been doing for my whole career? I have just, like, that would have taken me 5 months to ask that question. And this is in the first 2.5 minutes of meeting somebody. So it was, yeah. So I think they're not complicated questions, but it's just not being scared that you don't have to sort out the fallout. You just have to use that to signpost where's the right place for that person.
Exactly. And I agree. I mean, I had to use your example about people may tell you things, but not always want to give you the entire answer. Someone yesterday came out with something saying that they had stuff in their childhood, but didn't want to tell me. And I was like, that's fine. You don't have to tell me, but we're just aware. And if they want to then explore it more, go into it, they can later on when the
Yeah.
time's right for them. And we've been asking the NICE guidelines for pain. I've been suggesting that we also ask people about if their religion or faith impacts their pain, or if there's anything about their cultural background, or if there's any financial impact of their pain, which are quite, we ask personal questions about cord equina potentially or stuff like that, and
Hmm.
the weight loss. But these are quite personal questions too, talking to someone about their finances particularly. And at first I was like, oh God, this is going to be hard. And actually, most of the time people say no anyway. And I was also thinking about, you and I both say they may not always remember what you say, but they'll remember how you made them feel. They'll
Yeah.
probably forget that we asked the question after about a day. Um, but if we can set the right rapport, the right trust, the right message, etc., they'll remember that bit even more. Um, and most people, I haven't had anyone turn around to me yet and say, I don't want to answer that, or why are you asking that? Um, so something,
Absolutely. Yeah. And actually, further to that, I think actually it's often the opposite. It's because I've had the odd patient that have said, because you've just given them that space and they maybe even volunteer some of that stuff.
yeah,
And then they go, oh, but you don't need to know that. I said, yeah, I do. This is really important because I need to understand how it is for you. And then that almost gives them permission. And then the common thing, as I'm sure you've seen endlessly, is people say, oh, it's the first time anybody's really listened. And that is so powerful, as you say, and that's what they'll remember,
yeah,
100%.
yeah. We should probably talk about some shoulder stuff, Joe, because that's what probably people have tuned in for.
Oh,
Um, we might come back to this. Um, and this is going across shoulders. This isn't specific to one specific shoulder pathology. The first thing that I'm going to ask, common term we've been using for years, people, I still hear it or see it occasionally, but it's less now, is this term shoulder impingement. And I asked you, is the term shoulder impingement done? Are we finished with it?
we'd love to think it is, Ben, but no, it absolutely isn't. You only have to go on Google,
Yeah.
or having lectured recently in Europe, it's very, very strongly still alive in many, many circles, and particularly in medical circles and conferences and papers, and it's definitely still there. And I
Mm,
think, the attempt to move away from it was a really positive one because we knew the model was no longer supported in terms of that top-down model. There was also studies that showed for some patients it made them scared and think it was really serious, and because they've been lost out in the genetic lottery with this particular shaped acromion that they needed it chopped off. And so then we went through the whole subacromial pain. Then we decided that wasn't clever enough, so subacromial pain syndrome. Then it was rotator cuff related shoulder pain, but all as a way of trying to move to a model that said, actually, there's lots of stuff you can do and lots of things that affect your pain. But I think the big issue is that we still don't have consensus. Rotator cuff related shoulder pain is probably the most popular, but of course we can criticize that for being structure specific.
yeah.
But for me, it's something that gives hope. So I think the most important thing for me is if a patient comes and I say, oh, you've already seen your doctor. What did they tell you about your shoulder? They say I've got impingement. Well, my next thing I could say, well, your doctor's a bit out of date. That's not going to be helpful.
Yeah.
Or I could say, what does that mean to you? And if the patient says, well, he says I need some physio to get my muscles stronger. How do you feel about that? Oh, yeah, really positive. Why would I change that narrative?
Yeah.
What I
Yeah.
will do is, because we know about 55% of people are going to go and look at Google. I'll say, look, if you type it in on Google, you'll see all sorts of stuff, all sorts of different words, but it's all comes under this same umbrella. And the great news is the same things apply in terms of treatment options. If, however, I get a patient that comes in and says, oh, my doctor said I've got impingement, and I say, what does it mean? They said, I've got a bit of bone that needs chopping off and I don't know why I'm here. This is a bit of a waste of your time. Then of course we're going to have a very different conversation, but we're not going to have that until I've done the objective assessment and seen if I've got the ability to modify symptoms as part of challenging that narrative, which I obviously won't always be able to do. But I think for me, any label that we use has got to reassure the patient, validate their experience, and importantly, direct a path of care where injection may or may not be relevant, or whatever
Mm.
those options might be. And so I think, again, I don't have a favorite title, probably because a lot of the patients I've seen have seen somebody else. So the narrative they go away with, whatever they've been told, is a positive one that fosters their role in getting back to where they want to be.
Is it ever appropriate? I mean, there may be like, I don't know, GPs or medics that are listening to this. Is it ever appropriate to say it now? Impingement?
It's it's not supported. So, but again, again, I love some of the stuff that you've talked about in terms of tone of voice and how you present the information and what it is. And I
Mm.
guess if you put it in a non-threatening way, where you're saying basically there's lots of things can make your pain sensitive, and we just put this label on it because we can then target your muscles or get you moving in a different way, whatever the narrative you want to put around it. But I think it's not a correct label because, as I say, the kind of I mean, it was basically based on an essay by Charles Neer back in 1972, which
Mm.
then led this whole furor of operating and chopping off acromions. So, I mean, it's incredible when you look at evidence-based practice now.
Yeah.
So I think, the model is no longer supported, but there are people that still respond to that surgery. So I think what I would say to doctors is the narrative, because we know that particularly in cuff tears and actually probably in impingement too, what the doctor says has a massive impact on what the patient chooses to do. So if you give them the potential negatives, they're less likely to go for it. Whereas if you only give them the positives, of course they will. So I think in impingement, the key thing is to say, look, physio's got a 80% chance of getting you back on track. I don't expect to see you back here again. If you need to come back, your physio will send you, because then it puts us in the driving seat. The patient believes in us, rather than what can happen is, oh, you've got this hooked acromion, you probably need it chopping off, but we'll try some physio first. It's like, well, maybe just don't send them to me, because you've probably made my job twice as hard. So
Yeah.
yeah, I think the doctors can set us up to succeed, and it's a mutual respect, because there are still some patients where surgery is going to be the option, but we know that it's not necessarily because of anything we've done structurally.
I asked my team before this, well, what should I ask Joe? And about some of the, and I will be honest here, Joe, most of my people I see these days have pain everywhere, well beyond their shoulder. Um, but I asked them, people coming in with specific shoulder pain, what are these hard ones? And this is coming, but one of the common ones was they come in, let's say they've had some form of imaging, they've have some form of cuff tear. Now, you and I and many people listening to this will know that is very normal for people who don't know about it at all. Of course, many people in the public don't know that. And some people can get quite attached to that.
Yep.
So their question was, how do we try and sell or buy in the idea of rehab to those with a known cuff tear on their imaging?
So I think the thing that you said first was the most important. If we could just stop them having the imaging in the first place, that would make our lives so much easier, because then we wouldn't have to contend with that. So yeah, and I think it is a massive problem. It's tough, because if you look at the biggest reason patients don't engage with rehab is because they don't see how physio is going to heal a tear. So, and I think surgery is quite nice because it gives you time off work, doesn't it? And time to actually engage with the physio that you're trying to fit in with your mad life. So I think, I could go on about all the things about it's not affected with structure. You're twice as likely not to have pain as to have pain, but none of that is useful for the patient. And I think this is where there's two things I find hugely useful. The first is symptom modification, because generally the surgeons will have done some sort of gross resisted testing, like our full cans or whatever else, and it's painful and weak. And they'll say, oh, yes, look, that shows your cuffs weak and torn and whatever.
Yeah.
So I am a great believer that changing somebody's experience of pain is probably more powerful than a lot of the communication we can use, because again, it gives them confidence. I'm trying to change things. I'm kind of conveying that confidence that this is a process, and that ritual of assessment is important. So I would maybe just unload it by supporting it and get them to resist again. I do some things that I know just make them use their muscle system differently. And if that changes the pain, I know they've got a tear, so that's not going to change the fact there's a tear there. But where the evidence is helpful, it shows people who do well. It's a team. Very difficult to distinguish, when you look at the attachment. And actually, if one part of the team's not pulling its weight, the people who seem to do well are the ones where the rest of the team is working harder. So that kind of team analogy I find works really well. I've been through holes in the blanket,
Yeah.
dance socks, all that kind of stuff. And I just get patients saying, well, I'd buy new socks, or I'll just buy a new blanket. So I kind of went away from those quite quickly. Whereas this team thing, and then they say, oh, yes, but surgery will heal the tear. And it's like, well, would it be useful to know actually what we know about surgery now? And we have more and more papers showing that surgery does not change the natural history. Now, again, we get this as clinicians. We were said, don't say a tear, say it's normal age-related change, wrinkles on the inside. But again, the limitation of that is we now have qualitative studies showing us that for some patients, if you tell them it's age-related change, they're like, well, it'll never get better, because if
Yeah.
it's my age, it's just going to get worse. So much as we'd love a one size fits all, for me, it's always, what have you been told? What does that mean to you? If I can change their pain or their special test by some simple modification, what does that mean to you? And they'll often say, well, how can it do that if it's still torn? I say, because your system's really clever. We're just getting you to use it a bit differently. And also the big sell with anybody with a degenerative cuff tear is we do have evidence that if you have rehab first, you've got a 75% chance of not needing surgery.
Yeah.
But even if you end up having to have it, you'll do better than if you hadn't had the rehab. So really that particular group is a no-lose situation. So I've done a whole load of resources that are freely available, which are the questions patients ask and the evidence-based answer, but how to put it in a nice way. But I find in a lot of my patients, that team and that experience of change is very, very powerful.
Sure. Well, I haven't heard that one before.
Well,
It's
there you
nice,
go.
actually. I've heard the blanket.
Yep.
But as you say, someone might come around and say, well, I'd get a new blanket or I'd put a patch over it or something
Yeah.
like that, which is still a bit structural, isn't it? Compared to the team is a bit more cohesive. It's got multifactorial, so to speak. There's different parts to it. Um,
Yeah.
it's a lot it's more effort to replace a team member is than it is to cover over a hole in a blanket, so to speak.
Yeah, absolutely. But it also puts the kind of onus on them and what they can do. But then, of course, it's really important at some point that I introduce the conversation about, because the fact is, if we look at people with tears that are people with shoulder pain that happen to have a tear on their scan, it's more highly correlated with their blood pressure, whether they smoke, if they all those things that we all know about. And so it's also really important to signpost those as part of what I'm doing. But of course, my first question at the beginning is the patient sets the agenda. So what are you hoping to gain from today, or what are you hoping I can help with? And of course, those are the key questions. And funny enough, I had a patient like this the other day, exactly that. She'd been told she got a tear, told she needed surgery. He'd done the full cans. It was weak and painful. But she actually wasn't sure she wanted surgery. So that was always going to be easier for me. But I went through exactly that process. And so it was like the key thing was, do I need surgery? And the second thing was, if I don't, what can I do? So again, that then allowed us to signpost some of those other factors.
Yeah, absolutely. Um, so we also see people with shoulder instability. Um, there are some people that are very afraid of their shoulders popping out regularly. Some people do it as party tricks or part of their wider condition. But we know there are some people who will not want to move it in case it pops out again. Um, and even if some of them, there may not be they come in different types. And from what I can recall with these dislocators, you can tell I haven't seen a specific shoulder patient for a while. But only one's related to like structural, right? The other two are kind of control and genetic slides. And if there's no tear of anything like a labrum or something that can cause that to pop out repeatedly, that they have to basically, it's going to be rehab based. So how do we help someone who's worried about their shoulder popping out all the time get on board and basically not worry about it as much?
Yeah, so I think you illustrated beautifully in your introduction there that it's a complex construct because there's such a variation within instability presentations. But I think if you take the typical atraumatic, because we kind of had a group that we named muscle patterning, and I think when we look back, we realized that probably wasn't terribly helpful, because really what it was just illustrating was people where some of those protective strategies were so dominant, it was actually pulling the shoulder out rather than it falling out. But we have so much stuff now showing us that basically that fear is the thing that makes you more likely to redislocate. So of course it's something we've got to address. So I guess in lots of ways, as with everything we've talked about so far, it's assessing the patient's starting point, because we know that that fear can be driven by what was said to them when they went to casualty, what was said by people around them at the time, if they knew somebody that had it done. So understanding what underpins that fear. But of course it can also be that it just hurt like hell when they actually dislocated and they're worried about it happening again. And so from that point, once I understand that, that kind of gives me a template that I can try to challenge that. But again, the great thing with instability is we probably have more evidence for the relevant of actually targeting the muscle system. So it's 70% of the stability system. So actually saying to patients, look, the fact is your shoulder's dislocated, you haven't had any trauma. Generally, this is just a fact. Your kind of team have gotten a bit of a mix about whose job is what, and we just need to get them doing their job properly. And so, and then again, that's where the symptom modification. Now, some people might go, Joe, you shouldn't say that, it's structure specific. But actually, we have evidence that there are key things that set people with instability up for success. And actually, more people with instability do better than people with shoulder pain. And the strengthening narrative, it's not about getting people stronger, it's it's like everything. It's like if you get them to do something, it restores their faith, so they stop protecting, so they're less likely to dislocate. So I think that's where the evidence is helpful, because it does support that narrative. And often patients are quite surprised. And then I'll often say, look, can we just try something if they're still very fearful? And I'll get them to imagine that situation where they're in a house and it's dark and they're on their own and there's nobody around and they're watching a scary film, and then there's a twig cracks outside, and they're like, oh, and they're almost, you can see them almost thinking about the thing. And how does that make you feel? And they're like tense and stressed and whatever. And I said, well, how do you feel when you think about your shoulder? Well, the same. And it's just, it might not be that. That's a clumsy example, but basically trying to get them to see the link between their thoughts and their physiology, or their thoughts and how it feels, so that they start to see they've got control. And so then you can challenge that narrative, because we're saying, like, when you're protecting and trying not to dislocate, you're actually stopping the muscles that are going to stop you dislocating. So let's have a look at some strategies to do that. And again, that's why, of course, we can't always change things with symptom modification, but again, some really simple things that give them confidence that they can move with a sense of not worrying is, again, massively powerful.
And actually, you talking about the symptom modification, and I've seen it, especially with low back pain world as well. Peter O'Sullivan does this all the time with his
Yeah,
CST
behavioral
thing.
experiments.
Exactly, and we do that in our programs. We basically find the way that they can do it without that's comfortable for them, that they can tolerate, that has a shifts that process, and or they can reflect on, because they're gonna remember that experience a lot more than the words we say and our reasoning and stuff like that. And they may not always, let's say they do it and they find a different way to bend or raise their arm without worrying about it or certain things. They may not at the time go, oh, this is amazing. This is great. I feel so much. They may go, oh, okay, fine. And then come back and say, well, you know what? You might be right. But I think, yes, we sometimes get in the zone of expecting, well, if we say the right things, surely that's enough. And as you said, and I agree as well, it's not always enough.
No, I think that experience is so powerful and actually interesting with the instability coat. I mean, I've given one example of how I might address it, but sometimes what I'll do, particularly with those non-traumatic ones, is we'll just do I get, is it distraction, is it external focus, who know, but getting to a target. So I might have some flashing lights, or I might have some post-its with numbers or whatever, and then I'll just have my phone videoing and we just do some stuff and we're chatting, and then I'm like, oh, and then they move their arm far better without dislocating, and then it's like, how did that feel? What do you mean? I said, oh, you moved your arm really well. Well, I'm not sure I did. And then you got the video, and again, well, why did that happen? And it's like, well, because your brain's not worried about protecting you. So it's allowing everything to do its job properly. So let's have a look at some fun stuff you can do that will reinforce that at home. But like you say, sometimes it's too much and you can see the body language and I'm not ready to hear this, but that's fine. You just got to roll with resistance and build the rapport to the point they trust you. But as you say, I think those little changes and that being kind of, oh, maybe I can do more than I think is just really powerful.
Yeah, absolutely. So we talked about cuff and a weak and painful shoulder. We talked about instability and unstable and painful
You're sounding
shoulders.
like a real shoulder specialist now, Ben.
Ah, I see it's all coming back
Yeah,
to
got
me.
it nailed.
Now, well, the other one, my colleague was very curious about. So, in a stiff and painful shoulder, um, someone with frozen shoulder, and now people talk about X-rays and muscle guarding, which has been talked about, and we won't go into today. But let's say someone who you are happy does have a clear frozen shoulder, and you can tell them that eventually it can get better, but we all know it can take a very, very long time. And it's easy for us as the clinicians to sit there and go, great, you're going to get better, bye bye. Um, but it might take for them years potentially, and they're the one that's going to be suffering potentially with this.
I need to have a word with your colleagues. They're definitely coming up with all the challenges that we face on a day-to-day
That's
basis.
why you're here, Joe.
So I think we've got to be honest, it's a tough one, but giving hope is absolutely key. And what's really positive from the literature is if we get it right at the beginning and we're confident and give the right information, we can actually influence that trajectory of recovery and the experience that that patient has. So it's a horrible condition. Pain is grim, but I think this narrative that it takes years to get better is really being challenged. I think it will take years if you don't get the right advice and reassurance and some guidance as to the things that are going to help you get there in the shortest possible time. So I think the way I sell it to patients is it sounds like you're having a really tough time. It's clearly having a big impact because it always is. They're not sleeping, they can't do the things that they value, etc. I said, but the good news is there are some things that will potentially help. Worst case scenario, the painful phase lasts up to 6 months. If it was lasting longer than that, you'd be worried. So, it lasts in 6 months, but there are some things that we can do. So injection it's the one time. It's really supported as a first line intervention and is a game changer for patients. So again, it's about offering something that can potentially limit that painful phase. And then very much, there was a great paper by, I think it was Wong in 2017, that basically said the myth of frozen shoulder, fact or fiction. And it was basically saying this myth that doing nothing is the best treatment is no longer supported, and that actually people with intervention on average are better within 21 months, which is a much more positive narrative. Now, of course, we're not going to promise that, because if they've got comorbidities, they've got stress, they've got all the stuff, and that doesn't get addressed, then they probably will be in that group that could take 3 to 4, maybe even longer. But I think because we have a much better understanding of those factors, again, we can empower patients by signposting that. So again, it might be the menopausal lady who's not had the conversation with a doctor about her hormones. It might be, as you mentioned earlier, they're not sleeping, or the stress that was the trigger, or not controlling your diabetes. So I think actually this is where taking that bigger perspective about all the factors that influence pain actually allows us to help a really difficult group of patients by signposting lots of positive things that allow them to take a bit of control.
Yeah, almost, as you say, take control, put them in the driver's seat, give a
100%.
bit of, as you say, hope.
Yeah.
Even if it takes a while, there's various things they can do rather than just in the past, nothing essentially, or the old capture release, which I hear is not done very much anymore. Um,
I, I
um,
I think what was so important, what you said at the beginning, is it, but there is still this acceptance that it's years. And I also love that you said, saying to the patient, oh, yeah, it's frozen shoulder. It's horrible. It's all right. In 4 years, you should be a lot better. Because again, the information that's out there for patients, it's getting better. People are trying to provide better information. But I think there still needs to be more emphasis on what they can do in terms of lifestyle and stress, and what support they might need that makes it easier. And what's interesting in frozen shoulder, it's probably one of the groups where there's the biggest influence of group interventions, because they really value that shared experience of other people saying, oh God, this is just horrible. And I quite often either draw sometimes a vector, sometimes a seesaw, sometimes the old capacity cut from Emma at Psychology Mum, but then put in all the things that can potentially contribute, and then they can take that away and reflect on what they want to talk about. So again, it's I love that, because I quite often use that, putting them back in the driving seat of all the things we can do whilst acknowledging it's tough.
yeah, absolutely. Before we get into your hardest conversation, are there any other tough shoulder conversations you wanted to say that I've missed or didn't
No,
raise?
I think you've done pretty well there, to be quite honest. I think you've done very well. I think it is always, well, probably one of the ones I'll come on to with my hardest, but I think you've certainly covered the ones that cause us challenges on a day-to-day basis.
Okay, well, as you've set me up for it, and I ask everyone this, Joe, what's your hardest conversation you've had?
Well, you're going to forgive me. Because when I first read the question, I didn't see clinical question. So if I could share one conversation was sort of clinical, but taught me a lot about not never assuming. And that was actually my sister-in-law, who had a glioblastoma, and obviously wasn't going to live very long. Some of her symptoms had come back, and they were going back to see the specialist, and they said, would I go with them? Because they were always so stunned. They didn't know what questions to ask. So we went and sat in front of this guy who definitely needed some lessons in communication, but given the messages he was delivering to people on a day-to-day basis, I kind of got it. But it was basically, the tumor's come back, you're going to die in 12 weeks. We could operate again. If we do, you'll lose your speech. My advice, go away, live your life, and make the most of the last few weeks. But if you want me to do the surgery, let me know. And that was literally the consultation. And so we came out of the room, and my sister-in-law turned to me and said, well, you were rubbish. And I just went, sorry. She said, you were rubbish. You didn't answer any questions. I said, well, there weren't really any. I thought it was all pretty clear. And I know that must have been really tough to, sorry, I didn't say I know. I said, I'm sure that was really tough to hear, but what would you like me to ask? And basically, she and her husband just bustled me into the car, and we got home. So we got home, and of course, my husband and all his family are there waiting for the news. And they went in and said, and they said, oh, how did it go? He said, oh, great, I'm having another operation. And when you're just there going, and I remember speaking to them, and obviously and they were saying, well, so Joe, what was your perspective? And of course, I then had this situation where, does she not want the family to deal with this? And of course, I had to have a conversation with her before I could say anything else. But I remember speaking to my husband afterwards, and he said, it's all right for you. You're medical. And I said, no, it wasn't all right, because I absolutely understood the reality. I said, but what was fascinating is, because we always talk, don't we? People prioritize negative information. But in that situation, it was completely the opposite. It was like, I don't want to hear that. I'm not ready to hear it. So it was such a powerful lesson, and something else that probably underpinned my need to go and do a kind of formal communication training. So that was probably the hardest conversation I've ever had. But in terms of clinical, I think the thing that I was going to say does my head in, that's not very professional, is patients who come in and tell me something is out of alignment and needs clicking back into place, and they've been told it by 5, 6 other healthcare professionals that they've then gone for treatment for months and months and months to have it repositioned. And yet they still want me to do the same thing that hasn't worked over 8 years. And then they've got this broken model of themselves, that they have no resilience, that they should never lift anything or do anything because it'll pop out again. And they've been given messages to stop stuff. And I just find it hard, because generally by the time they've seen me, they come to see me, they've probably been going around that circle for 7 or 8 years, and yet they've still got local mechanical pain, not like your cohort that have got, multi-site persistent pain. And that's a difficulty as well, because they almost get put under that persistent pain umbrella, whereas they've still got local, very clear mechanical symptoms. And so I guess in those situations, you've got to build the trust and reassurance before you can kind of change that narrative. So you've almost got to roll with resistance without reinforcing it, but also then trying to unpick where that belief comes from and what it means to the patient and why they think it still comes out. And then again, I tend to use that experiment thing. Well, look, can we try something? I might do an exercise to achieve what I think needs to, and get them to see how that feels. And again, that link with how it feels and your thoughts and all that kind of stuff. But I think it's really difficult. And if I'm honest, I've had a couple of patients where I just knew I could help them, but this obsession with this asymmetry, or a scapula was tilted in the wrong position. I actually had a friend who's absolutely brilliant at CPT, and so there were a couple of times I actually used her, and I think that's fine. If you're, I think in those, I think I've got better at them, and I've realized that it might take me 3 or 4 sessions to get there, and I think that's kind of what the literature says, it can take that long. And there's some patients you won't, but I think that with those people, I had such a sense that they were ready to change, but for whatever reason, I wasn't finding quite the right tools. And so in that situation, having my colleague who's just awesome at that side of things was so powerful. She had a couple of sessions, and then we were on track, and the guy got back to doing everything he wanted to do. So yeah.
Yeah, especially it sounds like from multiple professionals as well, given that message, not just
Oh,
they saw someone once and got that, and that's been it. Like hearing it from 5, 6, that's adding to the evidence on that side of it, so to speak,
yeah.
against the opposite, so to speak. Out of interest, you've been working privately for the past few years now. Um, does the frequency of which that comes up, of the something's out of alignment or needs repositioning, has that altered since you've been in private more than NHS?
Yeah, because people seek care because they can pay for it. So
Mm,
often that's happened an awful lot more. And it's not even that you've seen the 8 people that have told you something out of position. They might have all told you something else is out of position. So now they're cross at the person who told them the wrong thing, rather than concentrating on something that might be. I had a lady today, and she was going on about, well, I know it's my posture, and I just need to walk around like this all the time. But she was walking around with so much tension. She had so much medial border scapular pain because everything's hanging on for dear life. And it's like,
mhm.
well, let's just maybe try it like this. But again, and you can't, I think what I've learned is, unless you understand what has driven that belief and where it's come from, it's very hard to start challenging that. But again, I think, as we've both agreed, I think that's where that experience of change is a really great way, alongside your words and that exploration, to kind of change that narrative. But it can take time.
Definitely can take. Oh, and as you say, there's some which it just won't always change.
Yeah.
Some we can, many we can, but some it's just that if it becomes our identity and if they're just so set, I think I've learned as well that sometimes you can. just drop little seeds, give them some information, and it might not be the right time, and that's fine. And I've seen it with colleagues or people that have seen me in the past where they go away and then they may come back 2 or 3 years later with someone else and then they're ready and on board. And I'm thinking, why didn't you say this to me at the time? But it
Yeah.
just wasn't the right time.
Oh, but
Um,
I love that, Ben. And I think that's the thing, because I think clinicians are so hard on themselves. And I know that I've done stuff that other clinicians have done and it's worked this time for exactly that reason, is they were ready to change. But I think the other thing that's really interesting about what you just said is I've had patients that their life is obviously a complete car crash. They've got all sorts of horrendous stuff going on. And I've actually said, look, I do think there's things I can do to help, but do you think this is right for you now?
yeah,
And patients said no, but can I come back when and that is so powerful because it's giving them permission, and we're kind of so desperate to do stuff. Sometimes it isn't the right time, and I think giving patients that permission is really powerful as well.
yeah, yeah. Actually, telling people they don't have to do something is something I've learned. Giving them an
Mm,
exit in a way
yeah,
is actually almost, as you say, empowers them. So, in the long term, can be more empowering than us just saying, do this or this. And sometimes we forget nothing is an option in a way.
absolutely.
Um, and thank you for sharing those stories, Joe, because it's important for people to know that it's not always easy, even with lots of expertise and experience. Um, Before we finish, I always like to end this on a bit more of a positive. And I know you're working, so we were talking before we started this privately and lecturing as well. And before that, your last NHS role was with the upper limb unit in Liverpool, you said,
Yep,
for NHS. And there was a team, right? An upper limb unit team. I think
yep.
all, tell me if I'm wrong, all female? Or was it
Until
also
well, until just before I left, and then we merged with Aintree Hospital, so we acquired a male.
a male then?
But we but we had the static team were female, but we had rotational staff, so that
Okay.
changed
What did that team mean to you?
everything.
Yeah.
And it's the thing I miss most every single day. In fact, I feel a bit emotional. That's a very, gosh, that is an emotive question. That was the hardest thing about leaving, because they're a group of, well, you know what it's like in the NHS, and I'm sure like your team, they're just a group of incredibly motivated, positive, glass half full, trying to do best for patients, people, trying to do research without the facility and the support because of the challenges of the NHS. And they just make me proud every day. Two of them were my fellows, so they kind of went through a 3-year mentorship post. And what's lovely is I haven't indoctrinated them. They're not afraid to go and look elsewhere and go to other courses. And I always make sure I invite them to anything I'm organising or sorting out with conferences and stuff, because I just want to be able to say thanks for what they're doing. And I feel so proud that they've just continued to grow the unit and keep it pushing forward and doing the best for patients. So no, I miss them hugely, and I miss that on the job discussion and learning. But it was the right decision, and it's allowed them to fly.
And we will send this to them and this goes out and they can enjoy listening to
We'll all be blubbing again. It
this.
seems to be a common theme when we get together.
Do you still get invited to Christmas parties?
Actually, no, I haven't been this year, Ben,
Ah,
but I did see we had the Hope conference here a week or so ago, and so I had a good catch up with them then, which was absolutely lovely.
good. Now, Joe, just so people know, and I'm sure they probably already know, so you are on Twitter or X, depending on what you want to call it, or LinkedIn. The course, Shoulder Steps to Success, there's dates on it, but can people reach out if they want you to come to them as well?
Yeah, absolutely. Absolutely. I'm fully booked for next year, but if you don't mind it being 2026, absolutely, you can reach out. But then there's my online course with Clinical Edge as well, which is obviously you can just watch at your leisure. So yeah, lots of options. But if you want me to do a course or you can't find a course, then just DM me on Twitter or whatever, and I can share that information, no problem.
The clinical edge is that's on demand, right? So people book themselves.
Clinicaledge.co. Yeah, we kind of launch it a couple of times a year, but you can go on a waiting list and they'll kind of notify you of when you can enroll and stuff. And it's kind of, I guess it's more than you can pack in 2 days. And obviously you can keep going back and looking at the content. I think some people love online, other people love face to face. And I feel very privileged that I've been able to do both.
And anything else you want me to plug or say?
No, just if I think just I love that you're doing this, because I think if we can just get people to reflect on what is, I think, their superpower, that we can all do it better. And honestly, I think it stops you getting burnt out and it allows you to really facilitate and coach your patients rather than fix them.
And I completely agree entirely. Thank you, Joe.